Hi there, I'm Zara Denejo, and this is the Roundup with Zara Denejo. Today on the show, we will be discussing the medical implications of having polycystic ovary syndrome. Polycystic ovary syndrome is a hormonal disorder that affects 1 in 10 women, sometimes as early as the age of 15. It is a condition that exhibits cysts on the ovaries, rendering them unhealthy and unproductive. Its symptoms include fatigue, hair loss, facial hair growth, and even infertility. In the studio with me to talk about this is Dr. John Ekwani, who is a consultant gynecologist with the Federal Medical Center in Jabi, Abuja. Thank you for coming to Roundup.
Thank you so much for inviting me.
So how does a woman get polycystic ovaries?
All right, polycystic ovarian syndrome, should I say the patient is born with it? Yeah, you must have the genetic predisposition to having such a condition. Actually speaking, from literature, the causes of polycystic ovarian syndrome is actually unknown, but there are certain associated factors that come or that are associated with it. And some of them you have already highlighted, and one of them has to do with a woman having polycystic ovaries itself, because the syndrome and the polycystic ovaries are not the same.
Right.
Having polycystic ovaries is a risk factor, and also having some medical conditions such as diabetes and other endocrine conditions in a woman are actually risk factors to having polycystic ovarian syndrome.
So I always used to hear from other people that there's like a trifecta of diagnosing a woman with polycystic ovaries, that she's overweight for her height and her age, that she is light-skinned, and that she has polycystic ovaries. I've never heard about, I always thought that the polycystic ovaries lead to endocrine conditions like diabetes and thyroid problems.
Well, not necessarily. I would just say there are associations.
Right.
Associations means that just like 3 good friends, when you see, let's assume Fatima, Zara, and Amina, they are always together. You see one person, you see Amina, then you look out for the other 2. Mm-hmm. They always flock together. Mm-hmm. So I'll call them associations. I won't say they are causal factors for each other. Mm-hmm. The factors or the features you mentioned, such as hirsutism, which is presence of hair in abnormal places for a woman, like the face, the chest, and the anterior abdominal wall. Or sometimes loss of hair on the head or on the scalp, as the case may be, can be a cause. Then overweight because of insulin resistance.
Right.
So some of these associations come along with polycystic ovarian syndrome. And of course, diabetes comes into place, because if you have insulin resistance, you are going to have some measure or some degree of glucose intolerance, which can range from the range glucose tolerance test to frank diabetes, as the case may be. And that's why we often say that they are associated with endocrine disorders.
Yes.
So aside that, you have increased body mass index. Like I said, there are often associations or deemed as associations. I wouldn't really say, or there's no full evidence to show that one causes the other. And the one you talked about, fairness of skin,
yes,
that's not actually
true. Yes.
I would say fairness of skin is just a coincidental finding for people, because I've seen dark people who have polycystic ovarian syndrome or who have polycystic ovaries. So color of skin doesn't have anything to do with it. Black people have it, white people have it, Caucasians have it, Indians have it. No matter the race you come from, you can have polycystic ovarian syndrome.
So when you have when you diagnose a patient with polycystic ovaries, what's the next step?
Well, often women with polycystic ovaries are in reproductive age group. Usually, I know some people take the reproductive age group from 15. Some others take it from 18 to the age of 45. But often they are in the younger age groups that often come down with this condition. And then what it often comes up with is there are features you're expected to see. And one of the commonest features of polycystic ovarian syndrome is what we call in medicine anovulatory cycles. But for the patient, what she often experiences are irregular menstrual cycles. You find a woman who is supposed to be seeing her monthly periods, and you find periods of amenorrhea or absence menses, of ranging from sometimes 2 months to about 12 months. Some of them don't see their periods for durations as long as 12 months, and then they later see it, and they become worried, assuming that they are pregnant or assuming that there is some obscure medical condition that they are suffering from. So that is one way it often shows itself. Another way it often shows itself is for people who are married or who are sexually active. They can come with infertility. And the reason why they come with infertility is because of the first condition I mentioned, anovulatory cycles. That means a woman sees her periods but do not ovulate regularly. So it's difficult to predict when they ovulate. And so if she's going to be going with timed coitus, it's going to be difficult because you are really not so sure, or you don't have a reasonable assurance when you have ovulated. So it's going to be difficult for you to track naturally. So those are, that's the second feature it often comes, and those are the two main complaints that women present with in the hospital. Other things are associations, such as hirsutism, presence of hair in abnormal locations.
But when you've established, for example, when you've established that the patient has polycystic ovary syndrome, what do you do next? What do you do? What do you tell the patient to do next?
Well, we explain the patient's condition to her and explain why she is having such an issue. Now, you don't manage two people the same way. And I will give an example. If I see a 15-year-old girl with polycystic ovarian syndrome or with polycystic ovaries, and she's not married, and I see a 28-year-old lady with polycystic ovaries married, desirous of conception, I will not manage the two patients the same way. For the lady who is 15-year-old, of course, her challenge is not fertility. She will probably be in secondary school preparing to write her final exams.
Yes, so her challenge might be having a regular cycle.
Beautiful. So if that is her problem, two ways to handle it majorly. Number one is to counsel her so that she knows what she has. And that helps her to have a positive attitude to the condition. It's not a death sentence. So it's not something that is going to kill her if she doesn't do something about it. And since she's not in a reproductive relationship, what I mean by reproductive relationship, a relationship that she will be in and she will be desirous of getting pregnant, then the main complaint she will have oftentimes is irregular periods.
Yes, so hold that thought. We'll take a quick break, and when we come back, we continue with Dr. John Ekwani. Stay with us. Welcome back. If you're just joining us, this is the Roundup with Zara Denejo coming to you from Trust TV in Abuja. And we were about to hear how Dr. John would manage a woman in a productive relationship. All
right. So I was talking about the 15-year-old lady who is not married.
Yes.
And two things. Number one, I can just counsel her and let her be. Second thing I can do for her is to place her on oral contraceptive pills. And oral contraceptive pills will help to regularize her period. But again, that has to be with a lot of understanding, because there are social issues that surround a 15-year-old girl using oral contraceptive pills.
Yes.
If she's seen by her parents using oral contraceptive pills, the challenge will be, why is this small girl using oral contraceptive pills? Is she sleeping around?
Yes.
But that is where they have to be carried along in the process if she is under 18.
Yes.
Because they need to understand that the reason why we're placing her on pills is to make her periods regular.
Yes.
Not because she's sleeping around and is trying to prevent herself from getting pregnant.
Yes.
So that is the approach I can follow for such a young lady. If a 28-year-old lady who is in a productive relationship, heterosexual relationship, and is desirous of getting pregnant, then a number of approaches can be adopted. Some of them can apply to that 28-year-old lady, and some can also apply to the 15-year-old. Now, let me go back a little bit. Let's assume the 15-year-old is also obese, just like you said. Obese on the overweight side. And one thing I can do for her is to encourage her to lose weight.
I have a problem with that.
Yes.
Yes, because as a Pcos patient myself, struggle to lose weight, and it seems every time you go to a doctor, the first thing the doctor says, okay, you're overweight, go and lose weight, go and lose weight, go and lose weight. I've spoken to different Pcos patients from different backgrounds, and the one complaint that stuck out is that doctors seem to just think once you lose the weight, your symptoms will magically disappear.
There are literatures that lay credence to that. It's not just what the doctors feel, because most of what we tell patients to do are backed up by evidence. Literature has shown, or research, that if you lose about 5 to 10% of your body weight, some of your menstrual irregularities can be corrected just by weight loss. I know it's not easy to lose weight in our environment because, of course, dietary control, exercise are difficult habits.
But you do know also that it is more difficult for a woman with Pcos to lose weight than a regular woman who has normal ovaries.
Not necessarily.
It is more difficult. And yes, and this is the part where I think there's a bit of miscommunication between doctors and their patients. It's more difficult for you to lose the weight than if you did not have polycystic ovaries. So patients are frustrated and doctors are insistent. How do you respond to that?
Well, one thing I will say is that from the literature, because in medicine we work with literature, not with feelings. Okay? We work with literature. Now, technically speaking, you will say it's more difficult because of hormonal issues.
Yes, because of insulin resistance.
Now,
and
insulin
all
resistance can be tackled again from another perspective using drugs. Some people employ the use of metformin or glucophage to improve insulin sensitivity of the end receptors. That in combination with the regular exercise that you do, that means your oxygen utilization, calorie consumption is increased, and then of course you watch the kind of food you eat, and that's where the dietitian comes into play. You may not be able to lose weight on your own just based on using your head. You may have to employ the assistance of a dietitian, and they can help you to draw out meal plans, food plans that can help you to lose weight in combination with drugs.
But so far we've only addressed the physical symptoms.
Yes.
Women with polycystic ovary syndrome often complain about having anxiety and depression and mood swings.
Okay.
How do you tackle that?
Now, one of the key factors, just like I earlier mentioned, is knowledge. If a woman understands her condition, understands that her condition is a medical condition, not a spiritual condition, that in itself is a help to her. Because if you understand your situation, then you'll be able to help yourself, and you'll be able to seek the needed help to be able to use that. However, in addition to that adequate counseling, you may employ the use of a psychologist. A psychologist may come into play that may help to talk her into, make her to understand her situation, make her feel better about herself. Rarely do we use drugs to improve mood.
Okay.
But again, we also need to talk to her caregivers, such as her parents, her husband, and other people that form a support structure to her. They can also help her by not criticizing her, by not being judgmental. All that can help to improve her general well-being of herself. So those are the methods we use in being able to deal with depression, clinical depression, or they can outrightly meet a psychiatrist who will help them with that. But
you've spoken a lot about the use of drugs to sort out some of the symptoms. I'm particularly concerned about the birth control, the oral contraceptives.
Okay.
It seems to have a truckload of side effects that sometimes doctors do not prepare patients for. Yes. How do you I'm curious, how do you prepare your patients that you've put on the pill? How do you prepare them for the avalanche of side effects coming their way?
Well, the truth of the matter is that there is no drug that doesn't have side effects, documented side effects, and it is the responsibility of every physician who is seeing a patient to communicate that in clear terms. Now, information, they say, is power. If you are able to understand that when I'm taking so and so drugs, I will have so and so problems, it helps you to cope better than when you are not even aware that you are going to have that. So that in itself is one of the solutions to the problem. The second thing is that, of course, there are criteria that need to be met before you can use combined oral contraceptive pills. And I must say that the recent oral contraceptive pills and the previous oral contraceptive pills that we had in the past are not the same makeup. We have very minute quantities, minute tolerable quantities of the estrogens.
So are you saying the pills today are better than 10 years ago?
Than 15, 10 years ago. Yes, they are. Because they have micro quantities of the estrogen and the progesterone, minimum tolerable quantities. So they may not be as, they may not have those kind of severe side effects like we used to do. However, if a patient has known clinical conditions that will make her unfit to use pills, then we will advise against it. For example, if the patient has a history of venous thrombosis, that's clot formation in the veins, has a family history, is obese, she may not be a good candidate for the use of combined oral contraceptive pills. We may have to counsel her for other methods. And that's why we talk about weight loss. We talk about use of insulin sensitizer, such as metformin, which will be guided by the physician that sees her. So again, the emphasis is not on drugs. The emphasis is, first and foremost, is on lifestyle modifications. And that's why we kept talking about weight, because we are often reluctant to use drugs, because we know that drugs are fraught with a number of side effects. So that is that. Then I was talking about the 28-year-old lady who presented with infertility. Now, there are a number of methods to deal with infertility challenges. We'll start from the simple ones. Of course, if the patient is screened, does not have blocked tubes, after doing a hysterosalpingogram or laparoscopy and dye test, and then the husband's semen parameters are good, because we may be dealing with fertility and we may be overly focused on the woman and not knowing that the man also has issues, such as semen issues, sperm issues, and dealing with counts and motility and the rest of them. So we have to investigate the couple as a whole. Now, and that being said, if the man is okay and the woman's tubes are okay, we can do ovarian stimulation, mild ovarian stimulation with drugs that contain estrogen, such as Clomid and timed intercourse.
Because I've heard about Clomid as they're Pcos patients who use Clomid. They buy it over the counter and use it to alleviate their symptoms, not to treat infertility.
Yeah, because it contains estrogen.
Yes, and they some of them open like Facebook pages and Twitter handles to say, you know, you don't need to be going to the hospital, just be going to the pharmacy down the road and buy Clomid. Which do you think that Clomid should be regulated?
As a matter of fact, in advanced countries, Clomid cannot be gotten over the counter without a doctor's prescription. But you know, in our environment, control over some of these drugs are quite loose. I know the government is trying its best through NAFDAC and through other drug regulatory agencies to restrict the dispensing of such drugs over the counter. But still, you still find environments or places where strict monitoring is not that available. So patients get it over the counter. So ideally, it shouldn't be an over-the-counter drug. It should be given only on a doctor's prescription and should follow usual prescribed dosages. So that being said, it can be used by a doctor to stimulate ovarian or follicular growths, and it can be monitored using vaginal scans. And then when their diameters reach acceptable limits, she can be triggered using certain drugs such as human chorionic gonadotropin. Some don't use it, some use it depending on the school of thought you belong to. And then she has coitus with her husband, and it's expected that after taking that drug, the woman is expected to ovulate within 30 to 36 hours after that. And if nature follows its normal course, she should be able to get pregnant, provided there is no other contraindication to pregnancy. But
doesn't it seem to be like a pipeline from Pcos to infertility to ovarian stimulation? Do you advise that, or should everyone just manage their symptoms and then think about whether they want ovarian stimulation, whether they want interventions like IVF and so on?
Well, interventions like IVF comes to play when other milder ways of dealing with fertility or infertility has failed. Just like timed intercourse, like I just mentioned, or use of mild ovarian stimulation with timed intercourse, or weight loss, if those measures fail, and a woman has been married for about 1 or 2 years, a young woman, and nothing has happened, then why not? She can be a good candidate for in vitro fertilization and embryo transfer. It has been helpful in alleviating the problem of infertility in many women that have this condition. So yes, IVF is one of the hallmarks for treatment of infertility, and can be reserved as a last option for younger women. But a woman who is older, let's say 35, I may be a little bit reluctant to do all those long routes, weight loss, go for Clomid stimulation, do timed intercourse, do IUI. I may just offer her straight away IVF because of her age. Because the longer she stays, the more likely she is to having premature ovarian failure.
When you say older women, how old are we talking?
35 and above.
35 and above.
Yes, 35 and above.
Yes.
So those are the women that we classify as older women. And such women, I don't have the time. Because a time may reach and then we'll begin to suggest donor eggs for them. And then depending on your cultural perspective or religious perspective or your personal belief, you may not readily accept.
I think that's another show.
Exactly. So you may not readily accept that. So that is why we often individualize treatments to a particular person. And I gave you 2 scenarios while I was discussing. And I just introduced a third one.
Yes.
The 15-year-old, the 28-year-old, and now the 35-year-old. So you can see I treated all of them differently.
Yes.
So that is, so the point is this. For we physicians, the treatment of polycystic ovarian syndrome depends on how it presents for that particular patient, for that particular couple, and for the particular presentation that the couple or the woman presents with. So we address her problem according to how she presents and according to her reproductive health needs.
Thank you so much, Dr. John. Thank you for joining us on the Roundup.
Thank you so much for having me.
As you've heard, the treatment of polycystic ovary syndrome only relates with how it presents. So if you don't have certain symptoms, you may not be exposed to certain treatments. I would advise stop buying Clomid over the counter. Please see a consultant gynecologist. Don't just see a GP, don't just see a physician. See someone whose job it is to take care of your ovaries. I'm Zara Danejo, as always, and I will see you next week.